Well, our second speaker for the Satellite Symposium, actually Dr. Zobair Younossi. We are very proud to have Dr. Younossi here in Saudi Arabia for the first time. He's well known in the world of hepatology and viral hepatitis. He's professor of medicine in Virginia Hospital and George Mason Hospital. He published hundreds and hundreds of articles about viral hepatitis, and he have an expert in non-alcoholic steatohepatitis. And today our second speaker also going to talk about hepatitis C. So thank you, Dr. Younossi, for coming all over. Thank you.
Thank you very much. Thank you. Thank you very much for inviting me to this wonderful country and this wonderful presentation that I'm going to give in this symposium. Let me just find my slides now. So you heard this fantastic presentation by Dr. Sinai about sustained virologic response, and there are going to be 5 talks tomorrow again about sustained virologic response, and I'll give a few of those. What I'm going to do in the next 20 minutes is to tell you about other important outcomes, what is beyond virologic cure. It's important to remember that hepatitis C is a systemic disease with both hepatic and extrahepatic manifestation. Now, the hepatic manifestation of hepatitis C, of course, is well known. We know that it causes cirrhosis and liver cancer. The extrahepatic manifestation of hepatitis C is less emphasized. We know that cryoglobulinemia, type 2 diabetes, porphyria cutaneous thyroiditis are very strong association with hepatitis C. In fact, we just presented a meta-analysis of all the data for extrahepatic manifestations. As you can see, the risk of some of these extrahepatic manifestations in patients with hepatitis C is tremendous. Mixed type 2 cryoglobulinemia risk is almost 11%, or 11 times higher. The hepatic manifestation of hepatitis C is well known. In the United States, hepatitis C is the #1 indication for liver transplantation and also the #1 cause of liver cancer, although non-alcoholic fatty liver disease is catching up quite rapidly. We also just heard that over the past 5 years or so, the treatment of hepatitis C has been revolutionized. We are talking about achieving something that was unheard of or unimaginable a few years ago. We are achieving 98 to 100% sustained virologic response rate with only 12 weeks and possibly 8 weeks of treatment. Now, what we don't know is that there is also a more comprehensive benefit of achieving cure. So when you look at hepatitis C and its treatment, really you're looking at a number of sort of endpoints. The clinical endpoints that you're looking at, HCV RNA or liver fibrosis, by themselves, they really mean nothing. They mean very little. They're only surrogate of survival, meaning that if you get rid of the virus, you improve basically fibrosis, that will reduce mortality and improve survival. So they are a surrogate of survival. When you look at patient-reported outcomes like quality of life or adherence, they really are surrogate of patient experience, and that I think is quite important. And I'll discuss this, why we see the difference between efficacy rates and effectiveness in real world. And then the third outcome that's important is economic outcomes, like total burden of disease or cost per care or cost per cure. And these are surrogate markers of resource utilization. Now, this data was published recently, showing clearly that 5-year survival of patients who actually achieve sustained virologic response is better than patients who do not achieve sustained virologic response. So cure can actually improve survival. I will show you data that cure also improve a number of patient-reported outcomes. And I will also show you data that cure will actually improve economic outcomes. So let's just actually define what are patient-reported outcomes. It is really, PROs are a part of the spectrum of the outcome. You're talking about clinical outcome, and these are things that are reported by clinicians. You're talking about physiologic outcome like a HOMA score or a hemoglobin A1C. Caregiver outcomes or outcomes that are actually reported by caregivers, those are things like functional assessment or dependency. Patient-reported outcome, this is defined by the FDA as those measurements that directly come from the patients without any change or any modification by anyone, including clinicians. It is an umbrella term, so it includes things like quality of life, it includes things like well-being or adherence. So there are a number of things that come around this or work productivity that are reported by the patients. Why do we measure PROs? Well, because we want to deliver patient-centered care. The most important outcome to the patient is how they're feeling, what is their well-being. They really are not looking at viral loads or amount of fibrosis or the F1 versus F2 fibrosis score. When you look at studies that looked at perception of patients about their well-being versus physician, there is actually discrepancies that are quite important to recognize. The second reason that we actually measure PROs is because of policy, health policy in different countries. In the United States, we have something called Healthy People 2020. This is a government goal or policies that have been established to improve a number of different aspects of the US population, including longevity, including access to care, but quality of life is actually one of those goals for the United States government to achieve. Quality of life in PROs predict mortality. So in a study by Fasia Kanwal from Baylor, who looked at patients on liver transplant list, when you do multivariate analysis to predict mortality, MELD score obviously predicts mortality, low quality of life independently predicts mortality. So it's actually important from prognosis standpoint. And finally, it's important because that's how you can get the full impact of a disease or treatment. And I'm going to spend a couple of minutes over here because this is also important about differences that you see between efficacy rates that come out of clinical trials and effectiveness rates that you see in real world. So this is basically looking at any drug. If the drug is safe and efficacious and you have sustained virologic response in hepatitis C, ultimately that will reduce the risk of dying, which will increase the quantity of life. Now, the quality of life will qualify those years of healthy life to give you the net benefit. Now, quality of life or PROs also impact adherence. So, for example, if you have a drug like interferon that has a lot of side effects, it will negatively impact PROs that will then decrease its adherence. When you have a decreased adherence, then you get a gap between efficacy rates during interferon era to effectiveness. If you remember that the clinical trial of the first generation protease inhibitors reported SVR rates of 70%. When you went to CUPIC study, which was done in France, the SVR rates were in 40% because of a lot of side effects. On the other hand, if you have drugs that don't have side effects or make people feel good, then actually that enhances in efficacy because of enhancement of adherence that leads to actually more alignment between efficacy and effectiveness. And this is what we are seeing now with the new regimens, the all-oral regimens where you don't have a lot of side effects. So the delta that you would expect between efficacy SVR and effectiveness SVR is the fact that they actually don't feel bad and they are compliant, and I have data to share that with you. PROs and quality of life is not something that you can actually see or measure it directly, so you have to measure it with questionnaires or instruments. These are very difficult instruments to develop. It takes years to develop and validate, but it has to measure. These instruments have to measure at least 3 aspects of patients' well-being: social, psychological, and physical. Every domain is actually measured by a number of items or questions. They're scored, so the higher the score, the better the quality of life. And they have to have good psychometric sort of qualities and characteristics. This is a very difficult area. In fact, if you go to the FDA and look at getting actually approval for a drug based on PRO, there's probably no more than about 5 drugs that have been actually approved by the FDA based on PROs. Extremely difficult criteria to meet when you go for drug approval. Let's just look at hepatitis C. When you look at hepatitis C, there are really 2 issues we're dealing with. The impact of hepatitis C as a disease on patient-reported outcome, and then on treatment. On the treatment side, if you have negative sort of impact, then you will have a negative quality of life. And this is really all driven by side effects. If you achieve sustained virologic response, you improve patients' reported outcome. Just give you some historical background. This is a study that we did, well, now it's almost 10 years, with Brendan Spiegel from UCLA, looking at patients with hepatitis C with healthy controls. These bars that you see is different scales of a questionnaire called Short Form 36. And as you can see, there's substantial impairment of quality of life of patients with hepatitis C. What happened when you gave them interferon or interferon-based therapy? This is actually a study that we just published 2 years ago, combining fission and fusion, some of the studies of Gilead. The red bars basically show you summary scores of SF36. And you see that when you gave interferon to patients, you have a rapid decline in quality of life that continues to basically hit the bottom, and then when you stop, it comes back up. The blue lines are sofosbuvir and ribavirin, so it does not have interferon. Now, interestingly, when you see that, there is not much change in physical health. When you see that here is that for the first time, you see a slight, mild decline in the mental health aspect of quality of life. Now, this was the first time that at least I noticed that there was actually a mental side effect related to ribavirin that was masked previously because of the side effect of interferon, and that's now actually been proven. What happens if you take both interferon and ribavirin out? What happens to PROs? Well, the top line shows you clearly what happens. You basically get an improvement of quality of life in other PROs like work productivity during treatment. That is the first time that anyone has shown that you can actually improve patients' quality of life during treatment. What is interesting is that when it happens when virus is gone. So you get viral eradication. We happen to have basically virus data. I have about 5,000 patients in the database, mostly from Gilead Sciences, all clinical trials, so I can do this kind of analysis. You could see the improvement that happens right at the time that virus is eradicated. Why is that important? Well, it's important because previously we thought that the quality of life issues of hepatitis C is not related to the virus. It's really because these patients come in with all kinds of psychological comorbidities or physical comorbidities. For the first time, you show that as you eradicate the virus or suppress the virus to negative, you actually improve. The other interesting thing that you see here is that the red line shows you the ribavirin line. This is basically LDV soft with ribavirin. You see some improvement that is related to suppression of virus, but it takes about 2 weeks for ribavirin side effects to happen, so then it actually flattens out until the end of treatment, then it actually catches up once you stop treatment. What happens if you cure patients with hepatitis C? This is basically looking at 4 different questionnaires: Short Form 36, FACITIF, which is a fatigue questionnaire, CLD-QHCV, which is a disease-specific questionnaire that I developed and validated when I was at the Cleveland Clinic 20 years ago, and Work Productivity and Activity Index, which is a work productivity index. As you can see, in every aspect of PROs, once you achieve SVR, you actually get improvement all across. Another interesting issue is that, well, people had this controversial thing that, well, maybe this is all because they feel euphoric, they feel good. Once you follow them over time, they actually will get into their original quality of life. In fact, that is not true. We follow these patients. This is almost 3,500 patients. We follow them now for 24 weeks post-treatment, and this was presented at the liver meeting. And as you can see, PROs post-SVR continues to improve. Does it hit the norm, the general population norm? No, not yet. But I think in time it probably will. The most important predictor of negative quality of life is taking interferon, ribavirin. But once you achieve SVR, regardless of what regimen you use, these patients have improvement of PROs. Last issue that I want to make sure that we talk about in this context is the issue of advanced fibrosis versus early fibrosis. This is controversial in the United States because all the insurance companies basically limit treatment for patients with advanced fibrosis, and I think it's probably true in Europe as well. So when you look at patients with advanced fibrosis to the right here, and you look at patients with basic stage 3 and 4 versus or earlier fibrosis, of course patients with advanced fibrosis have more impairment of their quality of life. But if you look at their quality of life during treatment with LDV soft or after achieving SVR, they have the same response, meaning that their experience with the treatment and their benefit from a PRO standpoint is the same. So I argue that from PRO standpoint, you cannot differentiate the two patients. They both get quite a bit of benefit. The drivers of PROs are before treatment are things like depression, fatigue, insomnia, and cirrhosis. During treatment is related to the side effects, as I was just mentioning to you. Now let me show you a couple of sort of interesting data that also talks about treatment of extrahepatics. Chronic fatigue is very, very common in patients with hepatitis C. There really are two types of fatigue. When you talk to rheumatologists, there is something called central fatigue and peripheral fatigue. Central fatigue is related to cytokines, and peripheral fatigue is related to metabolic diseases. So when you actually, this is a study of 1,000 patients from different ION studies, and when you treat them with these drugs that are interferon-free and ribavirin-free, you see that fatigue, whether it's actually measured by activity, fatigue domain of CLDQ, or vitality of SF36 improves over time and after achieving SVR. So we try to figure out if there are any biomarkers of fatigue that you can look at. We took serum from different time point from Gilead, and these are for genotype 1 hepatitis C patients who were treated with LDV soft with or without ribavirin. And we measured quality of life in fatigue PROs and probably about 20 cytokines and other biomarkers. The bottom line of the study, as it's now fully published, is that having actually serum IL-8, elevated serum IL-8 was independently associated with having decreased vitality and more central fatigue through cytokine pathway. Another sort of interesting issue is this brain fog of hepatitis C that we have been talking about. That's even before people were giving them interferon. So you can find hepatitis C in the brain stem and white matter of patients who are infected, and it can cause emotional and some cognitive impairment. Previous studies have shown that when you do functional MRIs with MRS, there is actually changes in some of the metabolites. So a study that Nadavdal and I did, small pilot study of about 14 patients treated either with LDV soft, with or without ribavirin, 7 and 7. They have all achieved SVR, and we've done all PROs and also functional MRIs 3 times. When you see basically that after achieving SVR, that is a significant actually improvement of N-acetyl aspartate, which basically means that there is an improved in neuronal function after you achieve SVR. So the other interesting piece of this is that connects to this psychological sort of side effect of ribavirin is that this response was blunted in those patients that actually received ribavirin as a part of the regimen, meaning that ribavirin may have a side effect that's central. So this is all about PROs. There is no doubt that PROs actually are improved with new regimens, and if you achieve actually sustained virologic response, you actually make these patients and these PROs better in all aspects of it. Let me turn into another sort of part of the talk, which is economic aspect of hepatitis C. And I want to make sure that we understand something, that cheaper drugs do not actually mean cost effectiveness. And I just want to make sure that I define some terminologies. There are different types of economic analysis that people do. There is cost of illness, cost identification analysis, or cost minimization. These are done for budgetary purposes. So when you look at an insurance company, at least in our country, talk about these drugs being very expensive, they only look at cost. The more appropriate way of looking at something is doing sort of full evaluation, not partial evaluation, or doing cost benefit. Here, both cost and benefits are in monetary term. Cost effectiveness is cost, and the benefit is actually in real world sort of outcomes like SVR. So this is cost per SVR. The gold standard is cost utility, is cost per quality adjusted life years gained. It is really what policymakers use to sort of decide on what treatment to use. I'm going to show you data on economic burden of hepatitis C, both in terms of liver, extrahepatic, and work productivity, cost effectiveness, and cure and cost to the society. So the first slide has to do with a study that Stu Gordon actually published a few years, that the cost of hepatitis C will go up if you don't treat these patients early. Patients who actually undergo liver transplantation, or those who have actually advanced cirrhosis, they are much more expensive at that point than if you actually treat someone early on. Razavi, who actually does quite a bit of burden of disease sort of analysis, in 2011 did an analysis showing that in the United States, the cost of HCV-related liver disease, just as only liver disease, was $6.5 billion per year. Now, as I mentioned, hepatitis C is not just a liver disease. It's also associated with other extrahepatic manifestations. We presented this data this past year, looking at the estimates of cost of the top 10 extrahepatic manifestations in the United States. Again, the data is about $1.5 or $1.8 billion extra. Now, if we make the argument that patients with hepatitis C are fatigued, their work productivity has been shown to be reduced, they don't come to work, when they come to work they don't work very well, that actually has an economic toll on the society. We did this study some time ago looking at US and then 5 European countries, 5 EU countries. And as you can see, the cost of work productivity loss to the society in the United States was about $7 billion, and in 5 EU countries was about $3 billion additional dollars. So this is substantial. The total burden of hepatitis C is substantial. And I think this is when we talk to the policymakers, it is absolutely critical for them to understand that it's not just the liver disease, it's all these other extrahepatics and all the other things that we need to also pay attention to. Is treatment cost effective? So if you look at cost per cure and you compare different regimens, as you can see in the bottom, both for cirrhotics and non-cirrhotics. In fact, the new regimen, although cost per pill is quite high, when you look at cost per SVR, it's actually much lower, and this is fully published. And why is that? Well, because we treat shorter, because SVR is much higher, and you don't have side effects to manage. Because you don't have side effects to manage, your actually cost of the total treatment is lower. When you look at cost effectiveness ratios, or the gold standard I talked about, again, this regimen dominates from a policy perspective. Now, we took the societal perspective in this analysis. So in that aspect, at least for the United States, when you look at the threshold of $50,000 per QALY is what we look at willingness to pay, it was actually cost effective. Now, what will be reasonable? WHO suggests that you can take 3 times GDP. So for Europe will be lower, and for some areas it may be as low as 5,000 to 8,000 threshold that you have to meet, and of course it won't be cost effective unless you lower the cost of the drug substantially for those countries. So how about societal benefit? So I mentioned that these patients actually suffer from work productivity impairment. What if you cure it? This actually comes from work productivity scores from ION studies. And if you do this and put it in a model, the United States actually saves $2.7 billion per year just from work productivity, and the 5 EU countries another $500 million a year. So again, there is substantial evidence that there is improvement of work productivity that leads into indirect economic benefit. This is my last study that I'll show. This is value of cure and what that value brings to the society. This really has to do about what a country has to do in terms of investment to actually cure hepatitis C. And can we cure hepatitis C? We have the drugs. We don't have all the other sort of challenging issues of how to identify patients, how to connect them to care, or how to actually make sure that they're compliant. But if you model this, and we use a Markov model for genotype 1 patient, in the United States it's about 1.1 million genotype 1 patient. That was 2015. And the strategy was to treat all of these patients. If you do this, you actually gain 2.9 QALYs, quality adjusted life years gained. So this is amount of years of life that you gain that is quality adjusted. And if you actually equate one of those years to 50,000 to over 150,000 based on the threshold that you take, you can actually have substantial actually saving. So the cost of the regimen, and this was Harvoni, or actually the 3D regimens, could be about $93 billion. So it's quite a bit of money to treat all these patients. But when you subtract the cost of the drug to the benefit that you get from a societal perspective, again, the use as a society will benefit, but that will require investment. So to summarize, treatment of hepatitis C improves the following outcomes. I've shown you that clinically, hepatitis C cure improves clinical outcome of cirrhosis and ultimately mortality, which is what we're trying to accomplish. Hepatitis C cure could also improve extrahepatic manifestations. I showed you the fatigue data, neurocognition. The neurocognition data is now, we have another study of 60-some patients. That is what we are analyzing. Patrice Cacoub from France has data on cryoglobulinemia that's improved, so there is plenty of data there as well. We have also shown that actually treatment improves patient-reported outcomes and quality of life as well as work productivity. Economically, I've shown you that these regimens are associated with lower cost per cure, which is the cost effectiveness. And from a non-liver standpoint, the fact that it improves work productivity will contribute indirectly economically to the country. And for a societal perspective, it's cost effective depending on what threshold you take. It is cost effective in the United States and maybe some part of Europe. It may not be cost effective in other part of the world. But if you invest, and as has been done in a number of countries, I know Portugal has one, and I was talking to Dr. Colombo, my friend right here, Professor Colombo, that they have actually a program in Italy to treat patients. I know there is a great program that's being actually implemented in Egypt now, that if you actually put all of this together for these countries, the long-term cure of these patients will actually bring benefit to the society. However, I think it is absolutely critical to understand that what I actually develop a strategy for the United States, or what Massimo develops one for Italy, or if we develop something with Dr. Asmat develop something for Egypt, it is not going to be one sort of set of ideas fit all. We have to have country-specific strategies that will then be applied in those countries based on culture, based on access to the drugs, and based on sort of the economic situation. So, but I actually think that the future is very bright. Our challenge in the future is to get access to these drugs that are miraculous and make sure that we can implement it in the future. I'm going to stop here. Thank you for your attention.